Dr. Deshna.
I'm Dr. Niksha.
Welcome to Those Millennial Pediatricians. This is our podcast on all things pediatrics geared towards parents who just want the most up-to-date evidence-based information about their child's health. So this is a new episode called Things I'm Too Embarrassed to Ask My Pediatrician. Baseline, we understand that when you're at your pediatrician's office, things are a little bit chaotic. Sometimes you have as little as 15 minutes for a visit, which is really short when you have all these questions about, sometimes you're newborn, you're a new parent, you're like, how do I do all these things, or why can't I do certain things? And some questions we understand sometimes are just a little bit embarrassing to ask, or you're just too shy to ask. And then you're like, let me look this up on Google, which the advent of the internet has been great for many reasons, but Google is not the place where you want to give your info because it's a bunch of random people just giving information that
They're
is
telling you that you're going to die when you're not going to die.
Exactly.
Yeah.
So, and it's best coming from the person who is literally trained and has studied children's health for many years, that it should be coming from them. So, welcome to Things I'm Too Embarrassed to Ask My Pediatrician.
And I think to start this off, we were like, let's ease in by talking about all the embarrassing things we did in residency since we're coming hot off of the end of that. So maybe we can talk about a couple of mishaps in residency that we've probably both had multiple times.
I am an embarrassing person, big clumsy. Sometimes that can be very awkward. So it's just more to make you guys feel better that we're all in this together. We're all learning and we're all growing together. So don't even worry about it. Something embarrassing.
There's so many. You know, the one I just remembered actually that was really funny is when you and I were both on the inpatient team. Do you remember this? And we had a couple of new interns. I think it was the beginning of our second year, and you were running the list, which for people who don't know what that means, it means going through kind of all your patients, the to-dos, how they're doing, updates for the day. You were running the list with one of your interns. But before that, I was like, let me put on some music. Let me set the vibes for this workroom. And so I was trying to put on 90s hip hop, but I was trying to do the clean version. And I played this explicit song where it's a bunch of curse words at the beginning. And you were just about to run the list and you're like, okay, walk me through and then the song starts blasting. And it was a bunch of explicit words. And the two of you just looked at me and I was like, I'm so sorry. I was not trying to do this.
I forgot about that until you just brought it up.
I just remembered that.
It was very, very jarring because usually the playlist in the workroom, personally, I am a music person, so the tone really sets the day, energetic with calming stuff, some upbeat stuff, and then you have Aniksha playing the most.
Trying to play Fat Joe. Oh, what's that? I forget what the song was, but I was like, oh my God, I'm so sorry. I was trying to play the clean version of this.
It was maxed out and it was a string of F words. I have a really bad habit of setting my alarm, but then I set snooze 80 million times. So that the last snooze, it was 5 minutes before I had to be out the door and make it for sign out from the night team. And so I was rushing. I put my scrubs on. The lights weren't even on. And then I managed to comb my hair and make it out the door. But then anyways, we're in the middle of rounds and the fellow that is on with us gestures to me right after we finished presenting one patient and is whispers to me, I don't know if you know, but both of your scrubs are on inside out. And I look down and they're literally inside out. And I was like, have I been walking around? I've been walking around like this, mind you, for the past hour and a half. They were my figs scrubs. So anyways, yeah, that's my embarrassing story of residency. At the end of the day, it's all about personal growth. There's no such thing. Yeah, there's no such thing as an embarrassing question, mostly. There's no such thing as an embarrassing question. And as long as you're growing and learning from it, that's okay. This is all to say we're trying to make this more relatable. So, anyways, yeah. Okay. Question number 1. Does my child really need the HPV vaccine? Yes. Okay. So, and this is a good one to ask because this is also a question I think I get routinely in the outpatient clinic side, just because I think there's not a ton of awareness about exactly what the HPV vaccine is. So HPV basically stands for human papilloma virus, okay? And that is a virus which in some strains can cause genital cancers in both men and women. So the HPV vaccine covers about 9 types, right, of HPV strains, and these are known to cause all the known genital cancers that we know now. So essentially, among teen girls, infections with HPV types that cause most HPV cancers and genital warts, they've dropped by about 88%. So a drastic drop in genital warts and cancers. And then among young adult women, when they did these studies, HPV cancers and genital warts have dropped about 81%. Among vaccinated women, HPV strains that um, cause cervical cancers have dropped a little more than 40%. You know, we routinely recommend this at 11 to 12 years of age, although now you can get it as early as 9 years of age. I think a lot of the hesitation surrounds the idea that we're promoting, like,
Yeah.
you know, sexual activity or the idea of sex in girls as young as 9 years old or boys as young as 9 years old. And this is just not the case, right? The reason we want to give the vaccine this early is because we want kids to be vaccinated before they ever come into contact with the HPV virus. So that is why we give it so early, because the preliminary data, or, you know, not preliminary, the data shows that there's such a strong reduction in the incidence of genital warts in cancers and in cervical cancers. That's kind of the reason. And once I kind of explain that, there's a better understanding. Parents still go home and say, you know, I still want to think about it and read the data more thoroughly, but there's a little bit more ease once you kind of have that conversation with them. So that's question number one. Question number two. How do I know if my baby needs to be further evaluated for tongue tie? Basically, tongue tie, the official term is called ankylosing. So that basically happens when there's like a tissue called the lingual frenulum that attaches from the tip of the tongue to the base of the mouth. So that's what we routinely called ankylosing. And really, the biggest concern about it, there are degrees of ankylosing, right? So you'll have degrees of tongue tie that will determine how well your baby is able to latch and feed at a young age, and maybe even down the road, how they develop their ability to speak. So it can also affect speech as well. So tongue tie routinely is not really a concerning thing. There is a chart that we use. It's called the tongue assessment tool, and we'll put it up here so you can kind of look at it yourself. But we basically grade it based on the shape of the tongue, if it's heart shaped versus whether it's a normal tongue shape, how close to the base of the mouth it is, and how far your tongue is able to extend past the gum line. So we kind of use that scoring tool. Your pediatrician can use it. And then they also look at other things, right? Like objective things. How is your baby able to latch and feed? How well is your baby gaining weight? And those are kinds of the things we look at. And depending on how severe it is, we may send it to a specialist, to an ear, nose, and throat specialist, to see if it needs to be clipped. There's a misconception that pediatricians love to send people to get their tongue ties clipped so they can get a kickback from, like, you know, a specialist for referring them to get the surgery done. In reality, we are very, very conservative when it comes to this. We don't just love to send babies to get their tongue ties clipped, because in reality, this may be something they can grow out of. Next question. Why can't I give my baby honey? So essentially, the reason we are so worried about babies under 1 years old getting honey is because of the risk of botulism. It's essentially a neurologic paralysis that happens after your baby's gut comes into contact with a botulin spore. And this can be found in raw honey. So honey can have these botulin spores. And when your baby ingests honey, their gut is not mature enough to handle these spores. Their gut microbiome is immature, and also the acidity of their stomach is not high enough to prevent these botulin spores from germinating. So once they do germinate, there's a toxin that's released, and that causes a pretty scary paralysis. And the end result is hospitals end up having to put a breathing tube in the baby because their respiratory muscles are paralyzed and they can no longer breathe. So that's why honey is a big no-no. And the biggest pushback for using honey is, oh, our ancestors used to do this. It's a natural remedy. And I'm like, my answer to that is there's a lot of things that our ancestors used to do that, killed babies. So just because it makes our ancestors did it doesn't mean it's safe to do so now, and that's because of the advent of science and research. And the 1 year mark is interesting. I've also gotten questions on this, is why 1 years old? So around 12 months is the age that is believed to be where the gut microbiome is a little more immature and your stomach contents are acidic enough to support eliminating like all these botulinum spores. And then another thing is that the CDC has studied this, and the incidence of botulism decreased sharply. And I'll put a graph up with the epidemiologic data that shows that after 1 years old, the incidence of botulism decreased significantly. So that's why, it's not just an arbitrary number that we throw out. It's like, oh, let's just pick a number and decide that it's 1 years old. It's, based on a lot of epidemiologic data.
Okay. Our next question is, my young son has breast buds. Is this normal? This is one that I actually think happens a lot, and maybe parents aren't too embarrassed to ask it because they're like, okay, I actually want to make sure everything's normal because I'm not expecting this. But this is normal. And we see it a lot in both males and females. So as both boys and girls or, children are going through puberty, everyone pretty much gets breast buds. And I'm sure you've kind of seen this in your clinic as well. And so in female patients, we kind of expect this as part of puberty. But in male patients, sometimes parents freak out and they're like, this is not supposed to happen. But that's actually part of puberty in males too. And sometimes it can actually be asymmetric. So one can kind of happen on one side, and then the other one can kind of happen on the other side. They can be kind of different sizes. They can feel kind of tender. It can all happen in all kids of age. And it's very normal. It kind of resolves as they're going through puberty. So it's really nothing to worry about unless there's like something else going on where there's like signs of like an infection or there's other things that don't seem normal. Otherwise, it's really nothing to worry about. If they're getting it earlier than like the age of like 7, that's something to think about. If we're worried about puberty coming on way too early, that's something to tell your pediatrician about. And then if we're kind of still waiting for that to happen by the age of like 13, 14, we're worried about puberty not kicking in yet, that's also something for us to talk about. But otherwise, all very normal parts of growing up and part of puberty.
To endocrinology for those reasons you stated, if there's what we call early or precocious puberty, so any hair acne at ages that you shouldn't see it happen, or if it doesn't happen at all. So just a normal part of growing up.
Yeah, I think the onset of puberty too just really depends. Sometimes people go through puberty a little earlier based on kind of their background and genetics. Some kids go through puberty later because their parents are like, oh, I didn't actually go through puberty until like 13 or so, but everyone else in the class is going through it at like 10 years or so.
Exactly.
So it really can vary a little bit,
Yeah.
depending on a lot of different factors, but all that stuff is pretty normal.
Yeah.
Yeah. All right. Our next question is, my child still wets the bed. Is this normal and what should I do? So this is one that I guess is kind of like complicated and definitely is one that parents like worry about sometimes secretly, which I feel bad about. So there's a few different factors I feel like we talk about when a kid comes in and they're wetting the bed. So one is based on how old they are, if that's still kind of an issue that's happening. I think the other issue is, has it always happened, or is it something that got better and then happened again? So we talk about, has this child achieved dryness before, is what we like to say. Or is it something that they've always been wetting the bed at night? If it's something where they're pretty young and they've always been wetting the bed, then there's a lot of things that parents can do in terms of limiting liquids at night and then trying to get up in the middle of the night to go use the bathroom and then kind of training them out of that practice. Those kids, most often, they're like, okay, the older brother had the same problem and went through it. I went through the same problem as the parent. And it's just something that kind of occurs in the family versus.
There's a strong, I think, genetic component to it.
A huge genetic component for sure. There's a huge genetic component to all of these things.
A lot of things.
Yeah. Versus if the kid It's like, oh yeah, he's like never wet the bed before, and then all of a sudden this is happening again. Then it's kind of something we need to talk about, where it's like, is there something stressful going on that's causing it? The other thing we get a lot is like they're wetting the bed. Also, they're peeing a lot during the day, and also they're drinking a ton during the day, which is kind of flags for things like diabetes that you probably have heard about, or like this polydipsia, polyuria that we talk about. Other things we talk about are like, is this related to the kidneys? And so we ask a lot of questions about like what's happening at nighttime, what's happening at daytime, what else is going on, to kind of get a better sense. In a lot of situations, this is normal and gets better with time, but depending on what's happening and depending on their age, it might be a reason to see a kidney specialist or someone else, or even get some labs and make sure that everything's okay. But I've kind of seen the full gamut of this. I'm sure you have too.
Usually if it's not pathologic, or if you've ruled any like type of disease process out, the most really effective things is, like you said, limiting fluids, going to the bathroom right before bed, but also what we call enuresis alarms, or alarms that can wake your child up to go pee during the night if he needs to. So definitely some things you should explore with your pediatrician.
Okay. And then the last one we got, that I've never actually been asked this, but I know that like a lot of parents, I feel like, allude to this, is, do you get annoyed or do you roll your eyes internally when I'm asking about like home remedies or stuff I've seen on TikTok? And the short answer is no, never. I feel like we love our job so much, and the whole point of general pediatrics, or the whole point of our job, is to be that person that you can come to and ask whatever question you have, and we are trained to be able to answer that question in an evidence-based way, or to research more into it to find what the right answer is. And I feel like I've never been like, how dare this parent ask this question? And I definitely am not later after they leave be like, how dare they, like, this was so stupid. Like we said in a different episode, like, there really aren't dumb questions from parents, honestly. And I feel like there's a difference between the home remedies and the TikTok thing. And they kind of overlap a little bit, where I think now we're seeing on social media a lot of return to home remedies, or like cultural remedies that we do kind of across the nation, across the world. And I feel like there's like a difference, right? Like with the TikTok stuff, there's a lot of misinformation or things that just aren't true, that aren't evidence-based. And that's not okay, but still important to talk to your pediatrician about, because we can either confirm or dispel those myths if they aren't true, and then talk about what we should be doing instead, depending on the thing. But I think the home remedies, there's such a good place for home remedies and for cultural remedies and for alternative therapies and all that kind of stuff. I think we're big believers in that, based on our background too. And we grew up with a lot of home remedies and things that worked for us personally, even if they don't have like all this evidence to back them up. And so I feel like we always get these questions about like, I mean, for headaches, doing certain like massages, or taking certain like home remedies for colds and coughs. We've talked about home remedies and stuff like that. And I think there's definitely a place to talk to your pediatrician about those, as long as they aren't causing a lot of harm. Even if they don't have a lot of evidence, we're generally pretty supportive of those. I feel like a lot of kids now who are menstruating, or have their periods, get painful periods, if they don't want to be on any sort of hormonal pill or anything to help control their periods, they ask about like raspberry leaf tea, or they ask about like other things they can do because they don't want to take Motrin. And we have a lot of conversations about that kind of stuff, about like acupressure points and mindfulness and stuff like that. And those are all things that we talk about regularly, honestly. So
Yeah, I think sometimes, especially like social media, sometimes can make, pediatrics or physicians in general very anti-home remedy, evidence-based monsters.
evidence-based stuff is how we know it's going to work
How
for
we
your
know it's
kid, and
going
we
to
know we're not going
work.
to cause harm. So
Yeah, but we also want to support your beliefs, and as long as it's safe. Yeah. So with that, thanks for listening to things I'm too embarrassed to ask my pediatrician.
yeah, and I hope that this episode has encouraged everyone to ask those embarrassing questions to their pediatrician, because I hope we've shown that there really is no such thing as an embarrassing question. And that's exactly what we're here for, if anything. But
Yeah, I think we'll do this definitely again.
yeah,
And I don't think this will be the last set of questions we get. So keep on asking.
yeah, 100%. But with that said, thanks so much for listening to this episode. We hope you enjoyed it, and we'll see you at the next one.
Bye. See you next time.
Bye.